Audience, good afternoon. Thank you for that. I'm sorry you've had a little peek behind the scenes there. We've had a pretty flawless day so far, but we just had a bit of a drama connecting to New York. I don't know why, because we had a flawless joining up with Jason, with Nick in Seattle and Oregon and Portland. We had a whole collection of people. So I apologize. I don't know why we've singled New York out to be, but anyway, listen, it's great to see you. Thank you very much for joining us. Yeah, I know you've got a really interesting presentation for us, so I'll let you get started with that. And perhaps if we can leave some time for questions, that'll be terrific. Absolutely. So it's over to you.
Great. Well, thanks, Roy. And it certainly is a pleasure to be here for NHS Change Day. And having had a chance to look at the history of the event and its real purpose, I'm really honored to be able to be here today. And obviously, what I'm going to talk about is sort of a look into the future of health and social care post-COVID-19. And it's a little hard to sort of have this conversation, given the fact that many of us around the world are experiencing a second wave of COVID. But that said, is that while we continue to grapple and struggle with the challenges caused by the pandemic, I still think it makes sense on a day like today, we're thinking about change in the future and what's possible, to think about what that world could and frankly should look like in a post-COVID-19 environment. And that's really my focus today, is to talk a little bit about that. But first and foremost, I think we need to acknowledge the fact that COVID-19 has been a profound event of change. The human toll, the sacrifice, as well as the economic fallout is of historic proportions. It's truly been a global phenomenon, obviously with its start in China, and then it rang around the world. It's a unique event in modern human history, in my view, in the sense that it's rare that you have an event that so impacts basically almost every corner of the globe. And nations have, and parts of the world have tried to respond to this crisis. And frankly, some have responded better than others. And my belief in all of this is that we need to learn from the collective experience here. And as all nations seek to make improvements. I think there are commonalities in terms of lessons learned, things that were done well, things that were done poorly. And I think what the crisis has also done is laid bare some of the real challenges in health and social care in countries all around the world. And as I like to also say is that if anything else, this has shown that what happens in Wuhan matters in Brooklyn, and frankly, vice versa. And that we need to acknowledge the fact that we are one world, and that we need to start thinking that way, responding that way, and learning that way, so that the next time we have a coronavirus, we don't have to shut down the entire global economy and cause huge economic dislocation for millions of people just to respond to it. So in addition to the human toll, the thousands and thousands of individuals who've lost their lives, the millions of cases, the individuals who have been hospitalized, the people who are still challenged with COVID, long COVID, we're still facing this challenge today with thousands and thousands of people hospitalized, dealing with this disease, and we are almost certainly months of more of this into the future. But this is also, in addition to the human toll, caused a significant financial toll on nations. Billions and billions of dollars, euros, yen, other currencies around the world have been spent, whether it was buying PPE, funding additional health and social care services, dealing with the fallout, not just in health, but also in mental health. We even created a new term in the United States called demand destruction, which was caused because people were told to stay home. And as a result, our healthcare system, which historically is funded by what we refer to as fee for service, where you provide a service and then you get paid. That system, which many people have historically found is sort of as stable, didn't prove very stable in this environment. When people stayed home, they weren't getting those sort of elective procedures that caused that revenue loss, that demand destruction. And it really has shaken, particularly the US healthcare system significantly, with our state, New York State's largest health system, losing money in just almost $200 million of loss in about three months worth of the lockdown. And then also something that I think we haven't fully grappled with is the impact of delayed diagnosis and care. Millions of people who would normally have gone in for regular checkups and at those checkups have been diagnosed with cancer or anything else. Those checkups have been canceled, been delayed. As a result of that, I think what we're going to find out of this is a significant amount of disease that hasn't been detected. And as a result, there'll be even more consequence, both to the health system, but also to human lives. But I do think that it's important to note, and this is a great chart that I found in the Financial Times recently, which shows that that when the nations that did the poorest job in terms of grappling with the crisis, the nations that had the biggest impact also had the most severe economic impact as a result. And even for those who may discount COVID-19 as a public health crisis, and unfortunately there are far too many of those people, particularly in my country, but I think a growing number of people around the world, that I hope they realize that the pandemic has caused an economic crisis, and that the nations who grapple or responded potentially more forcefully and more effectively have actually seen the least amount of economic challenge. And I put up there at the top, at the upper left hand side of this chart, you see some of the Asian countries like China and Vietnam. And obviously China was the initial epicenter for COVID-19. And they've actually responded quite well as a nation, cracking down quite quickly in terms of movement and imposing some pretty strict limitations on things that actually help them recover quite quickly. And as a result, their economy has actually grown slightly. So while they were negatively impacted, they were able to take initial actions. And not saying that everything that was done in China should be done in other countries. But that said, you look at other nations, the UK obviously is on here, the US, nations that frankly have not responded as well, are really paying a significant economic toll as a result of that. And I think that's something that's underappreciated. We must respond better to future pandemics. We cannot allow this kind of economic dislocation to be the result of a poor response. So as I mentioned up front, as I see it, we've had challenges, weaknesses in our health and social care system in the United States and other countries around the world for a long period of time. And to a great extent, we paid lip service to those weaknesses. But those weaknesses have been laid bare in the clearest and starkest of terms during COVID. First and foremost is a tremendous underinvestment in our public health infrastructure. Weak surveillance systems, creating apps on the fly to try to do track and trace, and hiring people to try to do this kind of work. And all of that because even though many of us, myself included as a longtime New York State public health official, spend time doing tabletop exercises, preparing for pandemics in theory, just like this. And yet we did nothing as policymakers to really make the necessary investments in this infrastructure, and really have underfunded at a national as well as a local level our public health agencies. In addition to that underinvestment in public health, we also lack systemness. And this is where I think that I see some opportunities in the future. A move to integrated care, a greater sense of collaboration between the health and social care systems, I think is essential if we're going to be able to respond better. I think in many countries around the world, including particularly in the UK and in the US, that lack of linkage, that lack of connectivity, particularly between health and social care, particularly between hospitals and care homes, or in our case, nursing homes, has really led to unnecessary deaths and the spread of the virus. And I think we need to have a much greater sense of this and really break down silos in ways that we maybe in the past haven't been willing to do, but clearly that weakness, that lack of systemness has been a big problem and causing challenges here. I mentioned the fee-for-service system, the financing of how we pay for healthcare, also a lot of weaknesses were on bear there. And then lastly, and I think in many ways, most importantly, the inequality in society, inequality in access to basic health and social care services has manifested itself in tremendous disparities in terms of disease burden, death, hospitalizations, you name the statistics. These statistics are from New York City, where you see that people who, based on the color of their skin, particularly people who are Hispanic or Black, 2, 3, 4 times more likely to be hospitalized or to die as a result of COVID-19. It's more than just the health and social care system, it's society in general. But at the end of the day, we need to find ways to do a better job of addressing these inequalities. Otherwise, the next time we have this, we're going to have exactly the same thing, which is people based on their zip code, where they live, will be clearly impacted far more greatly. And that in a society in the 21st century, that in my view shouldn't be the case. So what does the future look like? And I'm going to give you 2 scenarios for what I think it could look like in 5 years from now. So not 10, 20 years in the future, but a future, within most of our lifetimes, hopefully all of our lifetimes, a future that, and I think policymakers, all of us in the health and social care sector have to make some decisions about which of these 2 worlds we want. And I think we all have an opportunity to make decisions today and in the near future as we come back out of the pandemic to decide what kind of future we want. So the first scenario that I'll talk about is a return to normal, which in essence is, and I put that in quotations intentionally, is a normal in which the pandemic ends sometime in early to mid 2021, and the world of health and social care largely returns or tries to return to the world prior to COVID. Now, health and social care are big, complicated systems, and they want to revert to form quickly. The status quo is well established, and it's hard to move off of that status quo. And I understand those system dynamics. And as a result, under this scenario, those system dynamics overcome decisions maybe by policymakers or even by all of us in the sector. And to a great extent, where we end up is a place very much like where we were pre-pandemic. Now, I am convinced that no matter what, there will be some changes, but in this scenario, those changes are pretty much on the periphery. We'll make some nominal investments in public health surveillance. Perhaps we will have an app that actually works for the next pandemic. And I do think things like telehealth, which have been unleashed globally, and while have been available, technology has been around for a long time, are finally being utilized. And I don't think we're going to put telehealth back in the a proverbial box. And I think we'll see increased use of it. Not as much as during the pandemic, but definitely more use even under this scenario. I do see tight budgets in the foreseeable future under this scenario, as well. We have a lot of effort around stimulus. That kind of stimulus from the government can't continue forever. And I fear, though, under this scenario is that we tend to think of health and social care more as just a cost category that needs to be squeezed, as opposed to an area where we need to make investments. And then lastly under this is that other megatrends, the aging of the population, consolidation in the healthcare sector, the move to value-based contracting and value-based costing continues. And there are some new models being tried, as there were pre-COVID, but that basically these trends continue as they did before. There isn't really a response to COVID more than what would otherwise probably have happened, with the exception of some things like telehealth. But basically, under this scenario, the system really learns very little from the experience, and that we decide as a global society to kind of stick our heads under the proverbial pillow and hope that this doesn't happen again. And my fear is that this is probably the path that many would expect, given the fact that health and social care has historically been pretty slow to move, given other things. But I do see a second scenario, and that's the second scenario is one in which the pandemic ends, but it actually generates a global conversation about really what should our health and social care system look like. What should our public health surveillance system look like? And that the carnage caused by this pandemic will actually drive the system at both a micro as well as at a macro level towards a very different plane. And under this scenario, policymakers around the world, ranging from a global to a national to a local, begin to investigate what went wrong and seek ways to move forward. Not in a way designed to place blame and such, but really in a constructive fashion. To start thinking about what can we do differently to respond to what almost certainly will be another pandemic at some point in the future. Public health really under this scenario is reimagined, and key investments are made while new models are developed to tap into the latest advances in complexity theory. What I remember back in New York was the epicenter, particularly in the periods of March and April. And we were seeing models generated by, McKinsey's and, a lot of reputable organizations that were showing when we were at 18,000 hospitalizations for COVID in New York, models showing that we were going to get to 36,000 hospitalizations, which means that there would be more people in need of hospitals who with COVID-19 than there actually were hospital beds in the state of New York. And those models caused state policymakers to make a whole series of decisions. Now, the challenge was those models were not very dynamic. They actually completely overestimated what the demands were going to be for things like ventilators. And as a result, we lurched from priority to priority, spent tremendous amounts of money on things like ventilators, when really where the money and effort should have been was on the PPE. And I think a lot of that comes down to the fact that our models of the past were not up to the challenge of the present. And we need to learn from this so that we do not have that same kind of errors in the future. And then lastly, providers. All of us in the health and social care system do some serious self-reflection and develop strategies for how we can be better prepared for the next pandemic. We don't stick our head under the pillow and hope it never happens again and try to go back to the way we were operating in January of 2020. But rather what we begin to say is all of us, and not just wait around for the government to tell us what to do, we all actually respond in constructive and effective ways. Also in this is I begin to see under this scenario, patients beginning to demand things differently. They themselves don't want to go back to the way it was. I think virtual care is a good example. The idea of having to wait for long periods of time to get access to services or to get an appointment when I can go online and access and talk to a physician very quickly. I mean, I think some of this is the patients and individuals will begin to use their feet to vote to move towards care models that will be more effective. And so as a result, that will put pressure on the system to actually respond to that demand. Also, I think that there are certain megatrends such as the move to value-based costing and payment, which will accelerate, and you'll see new care models, new ideas coming to the fore, empowered by those new payment models, including the move to more integrated care within NHS England, that I think will receive attention and will be praised and people get more excited about, and those ideas will be looked to be replicated much more quickly than perhaps they have in the past. Also, policymakers will stop paying just pure lip service to inequalities, and we will actually enhance the healthcare safety net and start actually measuring the healthcare experience along racial lines. And I think this is one of the things that, at least particularly in our country, in my country, in the United States, we do a very poor job of measuring health outcomes based on race. So as a result, if you don't measure it, you can't, it's oftentimes one of those things where you don't work towards improving it. And at the very least, that's got to start systematically in the United States and other countries around the world. And then lastly is this concept of the health system is really redefined. In the US in particular, we think of health systems as like a hospital system. We don't think about it as a geography. I think at the end of the day, if COVID's taught us anything, is that the spread of the virus happens within a geography. And we need those organizations, providers in multiple sectors, regardless of how they're paid and who governs them, to be able to begin to see themselves as working together and as a common system, and have procedures in place so that they can work together more seamlessly and not have to create these sort of connectivity just in the midst of in the midst of the pandemic. And that's where I get into this idea of systemness as being so important. So which scenario do you prefer? Personally, which one would you like? For me, at least, I would prefer scenario 2. I would prefer, I'm an optimist by nature, and I would like to see this as a real opportunity for fundamental change in how health and social care is provided on a global basis. And I think that if we have, I personally feel we should have no choice but to see this historic and horrific event as the stimulus to actually finally make some structural changes in how we provide these vital services in our communities around the world. But why am I an optimist? And I believe at the end of the day, first and foremost, I think health and social care lags behind so much of the rest of our economy and the way we live our lives. We can go online and order almost anything we want and have it delivered same day, next day, and we don't even think twice about it because it just arrives at our home. And thankfully, because even in the year of COVID, when we were told to stay home, that system, that supply chain, that ability to deliver things continue to succeed even under extreme and challenging circumstances. Our healthcare system and health and social care system doesn't function like that. It's still built around the provider, not the person. And so it's almost always it's at the convenience of the provider. And I think we need to begin to think very differently about that and create a customer experience using technology and other tools that puts the person and the citizen more at the center of the system, and providers adjusting and raising expectations around responsiveness. Also, is this, it sort of gets in the same point, is antiquated approaches such as an over-reliance on this concept of face-to-face. I mean, that whole concept to me has really been blown apart by virtual care and how much now can and should be done virtually. It opens the door to a much more expeditious way to meet the needs, and frankly allows the healthcare system to focus more effectively on the people who do need the face-to-face interventions. But also, I think at the end of the day, what we also need to bring into the fore is this idea of the health and social care system coming to people and bringing back concepts to the mainstream of things like house calls. And the fact that technology now makes it possible for so much more to be done by bringing a service to a person in their home, as opposed to making that person, particularly those with disabilities who are elderly, for whom transportation to and the effort to get to a healthcare provider can often be a very traumatic experience. And so we need to figure out how to harness that moving forward. Also, while it's way too early to completely reflect on the carnage, I do think that key stakeholders feel a need for change. And that I think that's a key optimism. I hear very little in terms of people who believe that ultimately that there isn't a need for a really serious look at this. Now, there may be some who will, so I say, Jason, in your country, there's certain leaders in key positions in national government who don't necessarily agree with you on that. I think even within the administration in Washington here, there are serious people who are very interested in learning from this. And so even I think in our country, but I think in other countries of the world, I do think I have some optimism there. But I'm also very interested in consumers in healthcare and using the word consumer and starting to think about this. And I know this can often be a challenging phrase, but I think that ultimately what we need to do is think about providing that better experience, thinking about bringing empathy, bringing a respect to individuals to the fore. I've been struck by some of the work we've done with a startup that's focused on helping Black women access services from Black providers, and how the research shows that when that happens, you get better outcomes, and that there's cultural and then as well for certain populations, linguistic barriers that oftentimes lead to worse outcomes, and a lack of respect that's shown to certain types of people based on their disease or diagnosis. And so I think we need to be, I'm optimistic that we'll have new models that will provide better care. Some of those are going to be startups. Some of those are going to be innovators within things like the NHS, hence the change day today. But I do believe that that and all of that, I think ultimately will put pressure on the legacy systems, the old world, and push that to move forward. And even those organizations will feel a need, a pressure to move forward. So that's really, as I say, I'm an optimist by nature, and having sat here in New York and watched the carnage that has been brought about by COVID-19, I hope, and as I say, remain believing that we will see this as a force for change, that ultimately, once we get beyond this pandemic, there will be an opportunity for self-reflection and improvement. And I'm hopeful that that will happen, not just here in New York, but around the United States and frankly around the world. Because as I said up front, if anything, COVID-19 has taught us that what happens in Wuhan matters in Brooklyn, matters in Manchester, matters in places all around the world, and vice versa. And so I think we need to make sure that this is not just a national conversation, but a global one as well. So that's it. I hope that's helpful, Roy.
Jason, thank you very much. If you just stop, we just leave that up on the screen.
Sure.
We're not too sure who can see your screen. We've had a slight problem with that, as you know. If you just stop sharing your screen and we'll get you full screen. There you are. That's great. Thank you. I mean, I do love your phrase. If it happened in Wuhan, it can happen. It can happen in Wolverhampton.
Yes, that's even better. I like that one better.
Well, it kind of the alliteration fits here. What I think is the striking thing for me is having. I mean, I've had an extraordinary day listening to people from all over the world. I mean, we were in New Zealand this morning, and it's the extent to which most of the countries dealing with this have made a mess of it. If you look at that in your second slide, and I'm sorry to talk about slides to people who haven't seen them, as we'll hack everybody off, but if you get in touch with us, we've got your slides and we'll distribute them for you. The cluster of the countries that did well is really pretty small.
Yep.
But the distribution of the health systems that haven't done well wasn't really the fact that they weren't funded health systems, wasn't really the fact that they were developed health system. I mean, we're really right down the bottom, and we've got, the NHS envy of the world. If you look at Spain, I mean, the Spanish healthcare system is pretty good. The Italian healthcare system is pretty good. The American healthcare system, well, it depends how you look at it. I mean, for some it's good and some it isn't, but it's capable of being good. The fact that it's a federal system, I think, probably screwed it up. But do you deduce anything from that, the cluster of people that have survived and done well?
Yeah, so I mean, China is probably the quintessential example here, right? Where they probably took amongst the most aggressive measures. They obviously were the first outbreak, and they took pretty aggressive measures to try to contain it. And then when they had the potential for a second wave, when you began to see the reports and the testing, they took additional aggressive efforts. Now, we can all sort of criticize whether or not they were as transparent as they could and should have been relative to letting everybody know what was happening in the very early days. And clearly the virus was spreading globally well before we originally knew what was happening. But I do think that those measures, that willingness to take and they in essence shut their economy down or shut down one of their true manufacturing hubs in and around Wuhan in order to be able to respond. I think that is a lesson, which is is when these things happen, I think we need to be willing to take strong action, but do it on a more of a micro basis. I think that, when we in New York, we also took very strict action. And now, we were, as I said, we were the #1 state in the country for cases in the very early days. And I said we are at 18,000 hospitalizations. We now have the lowest or third lowest infection rate in the country. We're at about 1%, and we're testing 100,000 people a day. So you can't say that our infection rate's low because we're not testing people. So we're testing lots and lots of people, but yet our infection rate's low. Now we're all very nervous because we're starting to see a slight uptick because of the second wave that's grabbed. And when you're one state in many without ability to control your borders, things are going to spread. But I said is that we've been very aggressive here in New York. We put in policies and procedures designed to close restaurants and bars, and then put those 25% limits in there. And it's highly controversial, right? Because of the economic impacts and such. But I do think that one of my lessons learned is doing those actions more quickly, having the surveillance mechanisms in place that really will work to allow you to identify cases and trace them, and taking aggressive action quickly, but in short durations and on a very focused, very localized way is probably, I suspect, one of our lessons learned out of this is how best to respond.
It's very interesting. We've got a great question here from Matthew Darcy. Good afternoon, Matthew. Thank you for joining us. I'll just, I don't know if you can see the question in the chat panel, but I'll read it anyway so everyone knows what it is. It says, Jason, you mentioned that that models meant priorities were placed in the wrong areas, example, ventilators rather than PPE. Do you see that as reflective of other countries, including the UK? There was a huge effort in the UK to improve ventilator capacity involving Formula One racing teams, but some of those initiatives were soon stood down before production. I'm guessing, you won't have seen this, but I interviewed the boss of NHS England here, Sir Simon Stevens, who I think you've met, this morning. And he was talking about our initial reaction. And he said, we based our reaction on modeling in good faith, because we thought, hey, epidemiologists, modeling, mathematics, these guys must know what they're talking about. As it turned out, it was a gross overinterpretation of the numbers. Yes. You've just said the same thing.
Yep.
It's almost as though you've listened to what he said this morning.
It's so true. It's so true. I think both it was, I think, especially the US and the UK, but I think more, it was a global phenomenon, was that the models that were used, and I remember the caveats, and you know, Roy, you and I talked about this, was that Governor Cuomo, my former boss, the governor of the state of New York, was holding daily press conferences and was very transparent with everybody about what the models were showing. And he was showing these models that were developed, and he would say very clearly who would develop these models. And it was like Columbia University and McKinsey, and there was all these different models that were used. They were all showing this upward trajectory. And, you know, as it became clear that the models were wrong, what he said a couple of times, which I was struck by, was that every time that the models were presented to him as the ultimate policymaker, what he was told was that they always put in a little caveat saying, we don't really know what impact masks or social distancing will have on these projections. So the two big interventions that were being recommended to everyone, right, to do, they didn't know really how to model those. So you could say they took the conservative approach and sort of underestimated their impact. But as a result of that, we all just, you know, shifted into overdrive. And in New York's case, I mean, I think when all the accounting is done, I think more than $1 billion will have been spent on ventilators that were not necessary or were never used and are sitting in a warehouse someplace. And but that was what, you know, people were convinced was what we needed because the models were showing it. And I think that we need, if we learn nothing else out of this disaster, we got to learn how to model this stuff better, because policymakers can't be given this choice. And what else are you going to do when the models that the experts are showing you are saying that this is what you're going to need? Of course, you're going to respond as aggressively as you can. And I think, you know, Simon's, you know, description of the situation in the UK is exactly what was experienced here in New York.
And of course, the seductive thing is, isn't it, for politicians who, you know, politicians are just ordinary people. I mean, we pretend they're gods and we look at them on the telly and, you know, but actually they're just ordinary people. Most of them have got a pretty average education, and most of them have never had a proper job before they became politicians. So they don't have, you know, this great wisdom that we all think they have. They're just ordinary people making some very tough decisions. And of course, if you and I would, you know, in my business life, if somebody had come to me and said, I've got this model and I'm going to model your sales and your production and your risk and whatever, and this is what you got to do over the next, I don't know, 3 months, 6 months, 3 years or whatever, I said, wow, you know, this is a guy with a big brain and a spreadsheet, and you better do that. And of course, in government, if a guy turns up with a big brain, a spreadsheet, and calls himself an ologist, in this case, an epidemiologist, I guess as a politician, what do? You can't say, I disagree with an ologist, because you won't get elected if it all goes wrong.
Yeah.
So do you think we've misplaced trust in epidemiology?
I would say this is that I think that the modeling that was done, and the modeling was, I think what happened was that some of it's just a lack of knowledge, right? Was that we haven't had an event like this before. We can talk about the, SARS, we can talk about the, go all the way back to the, 1918, the Spanish flu, but, anything, trying to compare what happened, at a time when the economy in the world was completely different, technology was totally different. It's almost, I don't think that's super useful. But I think at the end of the day is that, and I want to be careful in this, in the sense that I think what Governor Cuomo and a lot of elected officials around the world were doing was they were listening to the scientists. And I think ultimately that's what should be done, because I think when you started completely ignoring science is when you get into real trouble. And we've seen plenty of examples of global leaders. Let's go to Brazil, for instance, right? Where you definitely had carnage as a result of global leaders, completely wanting to ignore the science. And we're even having a bit of a debate now in the United States between, President Trump and Dr. Fauci about whether or not the federal government's leading person on this topic. But I do think that for the science, the scientists, the people who do these things, I do think that they need to learn from this experience. They need to take this information about the impacts of all these things, incorporate this into the model, so that the next time we are facing a pandemic, that we have better models that are more effective than in the past. And that's, I think, the key thing is that, because I don't want us, and I fear a bit, is people, look at those results and they say, well, we should never believe the scientists. Well, scientists were wrong in this case. They need to learn from this experience, but that doesn't mean that we discount everything that science has to say on something like a pandemic.
Yeah. And of course, the other issue that came out of this is leadership, isn't it? I mean, we've got a problem here now. I'm not going to get into the politics of it, but, we've got a row between central government and local government. I'm sure you're across what's happening here. Because we don't have a strong and convincing leader. We've got a conservative government, and most of our local authorities are Labour. So it's like the Democrat-Republican split. And, one is fighting against the other. And, we haven't had, a clear leader has not emerged. Even in the press conferences, we get a different minister every day coming with a different message, so we haven't got what with leaders are visible, have a vision, share it often, and there's only one leader. Here we've got a prime minister and a whole bunch of other people. So we've not had the emergence of a leader. But you mentioned it's Cuomo, wasn't it? Governor Cuomo in New York. I mean, we used to watch his press conferences. They used to be broadcast live on Sky TV with open drop jaws, with the way this guy was so frankly and persuasively talking about what was happening. And, he kept saying things like, I don't know what the answer is. Don't ask me. I'm trying to figure it out just like you are. And you thought, wow, what an authentic guy this is. And I'm sure that leadership is a big part of getting through this.
I couldn't agree more, Roy. And I think that Governor Cuomo is tailor-made for this kind of crisis. And he has been very, and I think in a lot of ways, what he has been willing to do is take ownership and responsibility for his decisions. And that means that, decisions relative to New York City public schools and whether they should open or not, highly controversial with people on both sides of the issue, was willing to sort of stand by, the decisions in terms of when and how to reopen. Things like, the restaurants and bars, highly controversial issue, local officials. It's hard if you're a local official, to be willing to take on, key local business owners, and try to shut down your economy when you see communities in other parts of your state or in your jurisdiction, or across the jurisdictional lines who aren't being told to close, aren't being told to lay off their employees. And so the governor has been willing in New York to be willing to, one, take the decision, and two, to own it. And I think that's, and you're right 100% about communicating in these daily press conferences, which still happen today, in which he is brutally frank with people about what he knows and doesn't know. And you know, in some cases, that's led to a pretty serious row between the governor and the president of the United States, with a lot of back and forth because they have very different approaches to how to respond to this. And so, yeah, I agree 100% that leadership is absolutely essential. And having someone willing to step up and take that role is key.
Yeah, and you say, Jason, he's still doing the press conferences.
Yes, still doing press conferences.
Really, I miss him on my TV. I must find him on CNN. He'll be there somewhere. We have a situation in Scotland where the First Minister of Scotland is still doing her press conferences every day. She's there, you know, smart, tidy, looks at business, and she's very, very frank as well. And, you know, here we have an entirely different communication strategy, which for me anyway, it doesn't work. You know, it's been really interesting to talk to you. I'm tempted to ask you that sort of, you know, closing question that lazy interviewers ask, you know, but I'm going to do it anyway, not because I'm lazy, but I can't think of a better one, because you know, it's the one thing question. You know, if we've learned one thing from this, what is it? Is it closing down early? Is it getting an app sorted? What is it? I interviewed Jeremy Hunt, and I know you know Jeremy. He's former Secretary of State for Health. He was talking about testing. He thinks we should be testing every member of every UK citizen once a week. Well, that's like 50, 60 million tests. Oh, certainly 30 million tests. If you're going to, you know, you could whittle it down a bit. Is it testing? Is it, I mean, what have we really learned? Is it leadership? I don't know. What have we learned, Jason, do you think?
You know, I'll say, first off, I hope we learn a lot. I'll wait and see how much we
learned is a lot.
Yeah, I hope I mean, the human and economic carnage caused by this is sort of, as I argue, unprecedented. I mean, you know, especially when you take into account the economic toll of this globally. I mean, you have to go back to, you know, the world wars to find something as dire and disastrous as this. But I would say is that, you know, I agree with all the things you mentioned, we learned, but I would actually say, if I had to pick one thing, I would say what we've learned is racial inequality is real. And it means that in terms of access to care, and just in terms of the overall economic situation. And as a result of that, because of the color of your skin or the geography in which you live, the neighborhood in which you live, absolutely impacts whether or not a pandemic, a virus is, you know, what likelihood you have of survival. And that to me is like, while we've talked about inequality and its consequences, and we do these sort of like theoretical models that if we didn't have inequality, like how many more people would survive, the numbers that are laid bare, just the death toll, you know, based on people where they live and the color of their skin, lays bare those inequalities that have existed. And while many of us in Western developed nations who have developed social safety nets and done things to try to promote economic, more equality, we have a long way to go. And I think, especially in this country, I think a lot of us, particularly those of us sort of on the more left of the political spectrum, I think wanted to amuse ourselves by the thought that, you know, electing a Black president was somehow a signal that we had made major progress. I think COVID-19 showed us very starkly that we have a long, long way to go. And obviously in this country, you know, the Black Lives Matter movement, the death of George Floyd, all those things, you know, in the midst of the pandemic, you know, I think to me, that is the biggest lesson learned so far, is that that this disease, this virus, you know, has laid bare those inequalities. And my hope, you know, we have to learn a lot from this, but I hope everyone in this country and around the world learns that lesson and that we don't pay lip service to that problem in the future, that we actually do something about it.
Jason, I think that's a fantastic note to end on. Let's hope we do something about it, and that's the lasting memory. I don't know where the time's gone. I've just looked up, and we're kind of moving towards the end of our time. I just want to check again. No, we're fine there. So let me apologize to you again. I'm not quite sure what happened with the slides. That's one of the great mysteries of technology, but we've got them. We'll put them on the Academy of Fabulous Stuff to download. They'll be up there by the end of the week. Thank you so much for giving us so much of your time. It'll be great to see you back here. I don't know when. Absolutely. I don't know when we're going to get on an airplane or get off an airplane. I don't know, but that's we'll see. So thank you for your time. Keep safe. That's very important. I see Sarah was joining us. Sarah, good afternoon. I see you've hidden yourself. Are you going to just flick open your video and say hi? Where is she? There she is.
There's Sarah.
She's the power behind the throne here.
Exactly. Exactly.
Very nice to see you, Sarah. I'm pleased you're both well. Anyway, thank you very much for joining us. If you've been watching, I hope you've enjoyed sharing a fabulous session. Jason, thank you so much. Bye-bye.
Thank you. Take care. Bye-bye.